Welcome to this Study Neuro lesson on the modified New York criteria for ankylosing spondylitis. In this session, we will examine how these criteria were developed, why they became the standard for many years, and how they continue to influence clinical practice and research today. This topic remains highly relevant. We will explore the clinical findings and radiographic features required for classification. Explain how sacroiliitis is graded on plain radiographs, and see how these findings are used to classify patients with definite or probable ankylosing spondylitis, while also considering the strengths and limitations of the criteria in modern practice. By the end, you should be able to apply these concepts with confidence. If you enjoy evidence-based neuroscience and clinical education, join the Study Neuro community on YouTube, Facebook, TikTok, Instagram, and X for more high-yield lessons and practical clinical insights. Let's get started. The modified New York criteria were introduced in 1984 as a standard method for classifying ankylosing spondylitis. They combine a person's clinical symptoms with X-ray evidence of inflammation in the sacroiliac joints, allowing clinicians to identify patients who have definite ankylosing spondylitis using a consistent approach. This was a landmark development. The goal was to bring greater consistency to diagnosis while also making research findings easier to compare across different studies, because patients could be selected using the same well-defined standards, which improved the quality of clinical investigations and supported more reliable treatment research. Consistency matters. These criteria were developed by van der Linden, Valkenburg, and Katz in 1984. Even though newer classification systems are now available, the modified New York criteria remain an important reference in medical education and continue to have value in clinical research. The modified New York criteria developed over several decades as clinicians searched for a more reliable way to identify ankylosing spondylitis, especially by improving how inflammation of the sacroiliac joints was recognized on plain radiographs. This changed clinical practice. The original New York criteria were introduced in 1966. They were revised in 1984, and the updated version refined the radiographic definition of sacroiliitis, which improved diagnostic accuracy and helped establish a common standard for identifying radiographic ankylosing spondylitis across many countries. That was an important advance. These criteria remained the international standard for many years. Later, the Assessment of Spondyloarthritis International Society classification criteria, introduced in 2009, expanded the approach by allowing earlier identification of axial spondyloarthritis even before clear radiographic changes had developed. The modified New York criteria include 3 clinical features that reflect the effects of chronic inflammation on the spine and chest wall. These findings help identify patients with established ankylosing spondylitis during clinical assessment. Careful examination is essential. The first feature is persistent low back pain with stiffness lasting at least 3 months. This pattern improves with physical activity, which suggests an inflammatory cause, while rest does not provide meaningful relief, making it different from the usual mechanical back pain. Another important feature is reduced movement of the lumbar spine in both the forward and side-to-side directions, because ongoing inflammation gradually limits spinal flexibility and makes normal movement more difficult over time. This reflects disease progression. The final clinical feature is reduced chest expansion for a person's age and sex. Inflammation of the joints between the ribs and spine can restrict movement of the chest wall, leading to reduced expansion during deep breathing and further supporting the diagnosis of ankylosing spondylitis. The radiographic criterion focuses on structural damage in the sacroiliac joints seen on plain radiographs. These imaging changes provide objective evidence of disease and form the central feature of the modified New York criteria. This criterion is fundamental
To satisfy the imaging requirement, the radiographs must show sacroiliitis affecting both sacroiliac joints at least grade 2, or more advanced disease affecting one sacroiliac joint at grade 3 or grade 4, because these changes indicate established inflammation with structural damage. The findings must be clearly visible. Radiographic sacroiliitis remains the hallmark of the modified New York criteria. Its presence, together with the appropriate clinical findings, allows patients to be classified as having definite ankylosing spondylitis.
The severity of sacroiliitis on plain radiographs is graded from 0 to 4, with each grade representing increasing structural damage in the sacroiliac joints, which helps clinicians assess disease severity in a standardized and reproducible way. The grading system is straightforward. Grade 0 indicates a normal joint with no visible abnormalities. Grade 1 suggests possible early changes, but the findings are not clear enough to confirm sacroiliitis, so careful interpretation is required. Grade 2 shows definite but mild structural changes, including small erosions or sclerosis, while the joint space remains largely preserved. Grade 3 represents more advanced disease, with obvious erosions, sclerosis, narrowing or widening of the joint space, or partial fusion. Structural damage becomes evident. Grade 4 is the most severe stage. At this point, the sacroiliac joint is completely fused, reflecting long-standing inflammation and advanced ankylosing spondylitis. The modified New York criteria classify patients into definite or probable ankylosing spondylitis based on a combination of clinical findings and radiographic evidence. The distinction is important. A diagnosis of definite ankylosing spondylitis requires clear radiographic evidence of sacroiliitis, together with at least one clinical criterion, because imaging confirms structural disease, while the clinical findings demonstrate its effect on the patient. Both parts are essential. The original publication also described a probable category. This applied to patients who had all the required clinical features without radiographic sacroiliitis, or those with radiographic sacroiliitis but no clinical manifestations, although this category is used much less often in current clinical practice. The modified New York criteria have several important clinical applications beyond diagnosis. They provide a consistent framework that allows clinicians and researchers to identify patients with radiographic ankylosing spondylitis using the same established standards. This improves consistency. In clinical research, these criteria help ensure that participants enrolled in studies have comparable disease characteristics, which strengthens the quality of research findings and makes the results easier to compare across different institutions and populations. Standardization is essential. The criteria also help distinguish ankylosing spondylitis from other causes of chronic back pain and are still used to determine eligibility for some therapeutic studies, although newer classification systems are now preferred in many research settings. The modified New York criteria have remained valuable because they are practical and reliable in everyday clinical practice. They use clearly defined clinical findings together with objective radiographic evidence, making the classification process easier to apply. Their strengths are well recognized. Another important advantage is their high specificity for established ankylosing spondylitis, which means patients who meet the criteria are very likely to have the disease. While international validation has supported their use across different populations and healthcare settings, this increases confidence. When interpreted by experienced clinicians, the radiographic findings show excellent reproducibility. For this reason, the modified New York criteria continue to serve as the reference standard for classifying radiographic ankylosing spondylitis, even though newer classification systems are now available. Despite their importance, the modified New York criteria have several limitations. Their biggest weakness is the requirement for structural damage to be visible on plain radiographs before the criteria can be fulfilled. This delays diagnosis. Radiographic changes often develop slowly and may not appear until 5 to 10 years after symptoms begin, which means many patients with early inflammatory disease do not meet the criteria, even though they already have active axial spondyloarthritis. Early disease can be missed.
Another limitation is that interpretation of sacroiliac radiographs can vary between observers, which may affect diagnostic consistency. For these reasons, the Assessment of Spondyloarthritis International Society classification criteria now support earlier diagnosis by incorporating magnetic resonance imaging and human leukocyte antigen B27 testing, allowing patients to be identified before definite radiographic changes develop.
In summary, the modified New York criteria remain the classic classification system for ankylosing spondylitis and continue to serve as an important benchmark in both clinical practice and research. Their historical importance remains clear. A diagnosis requires radiographic evidence of sacroiliitis, together with at least one clinical criterion, making the criteria highly specific for established disease, although they are less sensitive for early axial spondyloarthritis before structural changes become visible on plain radiographs. This remains their main limitation. Today, the Assessment of Spondyloarthritis International Society classification criteria are used more often because they support earlier diagnosis of both radiographic and non-radiographic axial spondyloarthritis. Even so, understanding the modified New York criteria is essential for every clinician. Thank you for watching. Join the Study Neuro community on YouTube, Facebook, TikTok, Instagram, and X for more high-yield neuroscience education and practical clinical insights. Please like, comment, share, and subscribe. See you in the next lesson.